The ambulatory venous hypertension is the most important pathophysiologic factor for venous leg ulcers. In a person of normal height, the venous pressure in a standing position is about 80 mm of mercury. This pressure decreases to about 30 mm of mercury while walking due to the combined effect of muscle pumps and normal venous valves. In patients with venous incompetence, this physiological pressure decrease during walking does not occur, and in patients with venous thrombosis and persistent venous obstruction, the impaired venous outflow results in an increase in venous pressure. Both these conditions are called ambulatory venous hypertension. Only compression devices exerting a strong pressure with high pressure peaks may overcome the intravenous pressure and reduce ambulatory venous hypertension. This is not possible with compression material exerting a lower pressure and no pressure peaks. Looking at compression pressure recordings and considering the intravenous pressure is between 70 and 80 mm of mercury in the standing position, it is possible to see that elastic compression applied at a pressure of about 40 mm of mercury can never overcome the intravenous pressure, resulting in a minimum venous diameter reduction. The venous hemodynamic impairment will be slightly improved. Inelastic materials, both inelastic bandages and inelastic wraps, exerting higher pressure and high pressure peaks can overcome the intravenous pressure intermittently, resulting in intermittent occlusion of the compressed veins at every step, so restoring a kind of valve mechanism. Inelastic materials which can restore a valve mechanism are significantly more effective than elastic materials in decreasing venous reflux, increasing venous pumping function, and reducing ambulatory venous hypertension. In addition, inelastic materials are more comfortable than elastic materials, as these high standing pressure and intermittent pressure peaks are exerted starting from a lower and comfortable supine pressure due to the absence of elastic recoil. The critical point is that inelastic bandages are difficult to apply. This study by Protz and co-workers showed that only 10% of expert nurses who used to apply inelastic bandages every day were able to apply the target pressure. 14% applied an extremely strong pressure up to 140 mm of mercury, which is useless, as the intravenous pressure is about 78 mm of mercury, and it is certainly painful and at risk of causing skin damage. The great majority of healthcare personnel applied a very low pressure, like that applied by a good elastistocking, which makes it useless and not cost-effective the material and time necessary to apply a complex bandage, to achieve a compression pressure which is similar to that exerted by an elastistocking. This is not the only study reporting the kind of data, highlighting the need for education to be strongly required before applying inelastic bandages. This is not the case with adjustable compression wrap. Some studies have proved that wraps are easy to handle, and even by patients themselves, after a short education period. Patients can apply and remove the wrap and adjust it when they feel a loose sensation. In this slide, you can see that patients who were educated to apply the wrap at a pressure of about 40 mm of mercury and invited to return after 2 days could maintain the same pressure and even slightly higher. The second study shows that after a short education period, nurses could apply the wrap with the proper pressure on each other and on their own legs. Given these characteristics, wraps can allow self-management, which is extremely cost-effective as they allow cost savings for both materials and healthcare professionals. We do not have many studies comparing inelastic bandages and wraps in ulcer healing. We have only 3 studies. In the first study by De Palma, the wraps was compared with Unabut bandages. The results were in favor of the wraps in terms of both effectiveness and cost savings. In the second study by Blecken, patients with bilateral post-thrombotic ulcers were treated with a wrap on one leg and a 4-layer on the other leg. The ulcer surface and ulcer characteristics were similar, but the wrap was more effective in healing the ulcer. Finally, in our study, the wrap was more effective and cost-effective than the 2-layer bandage in patients with venous ulcers due to superficial venous insufficiency. The more significant effect was due to better compression pressure maintenance. It is possible to see that at compression device removal, the baseline pressure is well maintained and even slightly and not significantly higher than at application by wraps, but it is significantly lower by 30% with bandages. So, in conclusion, inelastic materials must be preferred in venous ulcer treatment as they are more hemodynamically effective and more comfortable. In studies comparing elastic bandages and wraps, wraps were shown to be more effective, easier to handle, and more cost-effective than inelastic bandages. It may be time to start considering wraps as the first treatment choice for venous leg ulcers. It was a pleasure having you here.